Hello and good morning, everyone. We will start with today's webinar on End FGM E-Campus. Thank you very much for joining us. My name is Carol Arnau. I will be your moderator today. I am the Senior Project Officer at the End FGM EU Network, and I will be facilitating today. Now I will give the floor to our director, Marianne Gena, our director at End FGM EU Network. Please, Marianne, the floor is yours for the welcome words.
Thank you, Kara. Good morning and welcome, everyone. I am Marianne Gena, the interim director of End Female Genital Mutilation European Network, and I'm delighted to welcome you to today's launch webinars and masterclass for the End FGM E-Campus project. We are thrilled to have over 300 participants joining us for this event. And today here with us, we have professionals from various sectors, but also FGM survivors. And we also have professionals who are themselves survivors of FGM. Thank you for being here. So since 2023, the E-Campus, the End FGM E-Campus project has worked together knowledge and develop an online learning platform focused on female genital mutilation, designed for European professionals dealing with this issue. And this project is coordinated by the Mediterranean Institute of Gender Studies, MIGS, in Cyprus, and implemented in partnership with the Italian Association for Women in Development, IDAS in Italy, the Association for Family Planning, APF in Portugal, the Cyprus University of Technology, Cyprus, the End Female Genital Mutilation European Network for EU level, and the Group of Abolition of Female Genital Mutilation in Belgium. So before we begin, I would like to remind you for a few important house rules for this webinar. This event is being recorded, so if you prefer not to appear, please turn off your camera and change your name to guest. The audience will remain muted to avoid any disruption during this presentation, of course, and we have also live interpretation. So please feel free to use the chat for any comment or question, and we will do our best to address them to our keynote speaker. So this webinar is being translated into French, Dutch, Greek, Italian, and Portuguese. So you can select down there, in your screen, you can select your preferred language directly on Zoom. So if you need any assistance, please let us know. For those who speak Dutch, please note that in the bottom, your interpretation channel is labeled as German, but due to limitation on Zoom, but we'll guarantee that the interpretation will indeed be in Dutch. So it's just the name will change. So now let's talk to today's agenda. So we will begin with an overview of the platform and its benefits presented by our coordinator from the Mediterranean Institute of Gender Studies, MIGS, and facilitated by Dr. Christina Kelly. So after that, we will have the privilege to hearing from our keynote speaker, Dr. Jasmine Abdulcadir, who will discuss the overview of the FGM across Europe, social, political, educational, but also medical challenges. So this will be followed by a Q&A sessions. So we will then move to the technical aspects, including a step-by-step guide to the platform by MIGS, and conclude with closing remarks from End FGM European Network Policy and Advocacy Officer Najma. So it's truly an honor for all the consortium to present this platform to you in the form of masterclass and to hear from our keynote speaker, Dr. Jasmine Abdulcadir. So over to you, Kerat.
Thank you very much, Marianne, for your welcome words. Now, without further ado, I would like to welcome and give the floor to Dr. Christina Kelly, who is Senior Researcher and Project Manager in the Mediterranean Institute of Gender Studies, MIG, the coordinator of our project. Please, Christina, the floor is yours.
Hello, everyone. Can you all see me and see my screen? I hope you do.
Yes.
Great, great. Welcome today. A warm welcome to everyone who has joined us today on behalf of the consortium and the End FGM E-Campus and the Mediterranean Institute of Gender Studies. A warm welcome to everyone. I will use my next 10 minutes to give a brief overview of the project and the reason and the story behind it, of its development and creation. So we are presenting today the End FGM E-Campus, a long-standing project that has a rich history, which I will explain in a few minutes. It's a European knowledge platform offering practical skills in supporting victims and survivors of FGM. This is a collaborative project since the inception of the End FGM EU network, and our very appreciated partners and members of the network since 2012. Here you can see a very small screenshot, and later on I will guide you and navigate the portal. So what was the need? We wanted to tackle gender-based inequalities and eliminate violence against women and girls. We brought together experts from various fields, as Marianne perfectly explained in the beginning, on prevention, protection, and support, to build an e-learning platform for professionals from various fields in order to respond to the increased demand for specialist support services, focusing on FGM survivors. Our partners, and these are our current partners, but as I said, it's been a long-standing relationship with previous partners that also acted as peer reviewers and supporters of this project, and some sister projects that are linked to this portal, like the Communities of Practice and the interactive map of the End FGM EU network, which provides country-specific information for 16 countries. I will give you some brief overview later on these sister projects and synergies. Our aim was to raise awareness and provide expert knowledge on the effects of FGM on the physical, psychological, sexual, and reproductive health of women and girls, and to raise the capacity and develop skills of professionals to improve the health and needs and support, provide the support needed by women and girls living with the consequences of FGM, develop communication skills necessary for effective protection of women, especially in the field of asylum, migration, and other fields where frontline professionals also need this support and guidance on how to provide assistance, strengthening policies in the European Union and beyond on victims' rights and international protection, and of course, to prevent FGM. So we've developed the platform. We have developed 5 learning modules for professionals and providing practical skills to enhance multi-agency collaboration, improved quality. We wanted to contribute to improved quality of specialized services for affected or at-risk survivors and women, increased interdisciplinary dialogue and mutual learning, which was also the aim of today's meeting, and prevention of harmful practices, and in support of specialist services. Our target groups, the target groups of professionals that this portal is targeting, is immigration and asylum, health, education professionals and media, civil society organizations, shelters, victim support services, social workers, legal services, and the police. But of course, it's not limited to this. We hope the content and the material of the e-learning will be useful to many more professionals and students in universities or other groups that can benefit. We know that Europe is home to 600,000 women and girls living with the lifelong consequences of FGM. And we have information that every year 190,000 girls and women in Europe are at the risk of FGM. We also have the data from the UNHCR and many studies like the European Gender Equality Institute, the Fundamental Rights Agency, that all of them highlight that challenges persist in achieving adequate support services and integrated policies for the support of those affected by FGM. And we also know that, especially after the pandemic, there was a huge need to improve the knowledge of professionals to support women in the post-pandemic, but also in an increasingly volatile environment, but also in a digitalized landscape that acquired new significance and urgency, that information, specialized information, is made available to professionals in various fields in order to support these groups. In 2012, as members of the End FGM EU campaign, in the early inceptions of the End FGM EU European network, a group of us, of our membership, we saw this gap in training of professionals. And it was a pilot tested project that started with only 4 modules, and we pilot tested it for a few years. And then the need was so evident that the European Parliament supported a follow-up project, the pilot project, for a European-wide knowledge platform. This was between 2013 and 2017. We reached 13 learning units. I will not repeat the numbers in the screen, but what was important was that there was an increasing need for initial and in-service training of professionals. And of course, apart from the partners that we used to have and we still have, we also have been proactive in securing institutional support and endorsement up until today, many of which support this project until today, including UNHCR. Later on, we saw that this need also continues and that the platform was a key resource for professionals, partners, users, stakeholders. And of course, like anything that is linked to technology, it needs regular upscaling and maintenance. And as you know, being part of civil society organizations and the landscape, we constantly needed to find new resources, which is also a challenge. And the key here is that our users from the previous stages of this long-standing project was that the professionals thought it was a useful interdisciplinary multilingual learning tool for health professionals, but also for many other professionals in the fields of asylum, media, community work. Some of the endorsers that we have so far, and of course, a welcome to any endorsement or institution that is interested to support this initiative. I will link the email of the project in the end of my presentation. Thank you very much. The second part of my presentation will be after the keynote speaker, after the keynote speech, and I will help you navigate the platform shortly. Thank you very much.
Thank you very much, Christina, for your insights. Now we would like to introduce our keynote speaker, Dr. Jasmine Abdulcadir. She leads the Gynecological and Obstetricial Emergency Unit at the Geneva University Hospitals and collaborates with the World Health Organization and Swiss Network Against Female Circumcision. Dr. Jasmine is a renowned obstetrician and gynecologist specializing in female genital mutilation, also a TED speaker, researcher, and author. Dr. Jasmine is recognized for her groundbreaking work in improving care and prevention for women and girls affected by FGM. It is an absolute pleasure to have you here with us. Over to you, Jasmine. Thank you very much.
Good morning, and thank you very much for this invitation to such an important webinar. I will talk about the challenges, social, political, educational, and medical challenges when it comes to female genital mutilation or cutting across Europe. So I have a disclosure before starting my presentation. I'm an obstetrician and gynecologist, and particularly a vulvologist and sexologist. So my presentation contains a few pictures of vulvas of different ages, different colors. All these pictures have been obtained with an informed consent and are all healthy pictures that are already published. But each time that there is a slide with a picture, I will make a warning so that those among the audience that do not want to see a picture can turn off the screen. But it is important as this is a scientific event that aims at improving training and deconstruct myths to speak without only drawings. And I acknowledge the fact that the audience is very wide with different backgrounds, professional and life experiences. So I will make a warning each time that I present a picture. So it is a great pleasure to be here to talk about female genital mutilation or cutting, mutilation génitale ou sexuelle. There are many different terminologies, and it is important to start about definitions as there are current debates and challenges. According to WHO, the official definition defines female genital mutilation as any procedure that involves the partial or total removal of the female external genitals for non-medical reasons or any other genital injuries. And as you can see, there are so many terminologies, official terminologies, unofficial terminologies. But this raises challenges in different genital cuttings across cultures, sex, and gender that can be medicalized or not. This is because vulvar, penile, and intersex genital cutting or surgeries are and have been performed on young and adult people in different countries, times, and cultures around the world, and the concept of medical necessity, normality, beauty, and the criteria for giving an ethically valid consent to certain genital modification are not a matter of universal consensus, and this can change in time. So just 2 days ago, we submitted a letter together with colleagues coming from bioethics, law, and medicine to answer to a comment that you might have seen on The Lancet a few weeks ago about medicalized female genital mutilation. And last year, also, Professor Fusaski published a paper where she discusses about terminology and definitions. So Professor Fusaski mentions a term that was a new term last year of gender genital modifications. And under this wide umbrella, then she talks about different modifications, including female genital mutilation. And in this letter that I don't know if will be published or not, we propose a term of unethical genital modifications, saying that there can be procedures that involve partial or total removal of a person's genitalia, because WHO only talks about female genitalia, or other injury to a person's genital organs that are medically unnecessary and done without the informed consent of the affected individual. And those two asterisks are quite important because we need to define what is medical unnecessary and what is an informed consent. WHO, in addition to the definition, has proposed a classification. And from my next slide, so when you see this little symbol on the right side, in my next slide, there will be some pictures. So those that do not want to see pictures can turn off the screen. So WHO distinguishes 4 different types with subtypes. I will change my slide. So type 1 is the cutting of the clitoral hood, if it is a type 1A, or cutting of the clitoral hood, or together with the glans or the body of the clitoris, if it is a type 1B. Type 2 can be the excision of the inner labia if it is a type 2A, the inner and outer labia with the clitoris if it is a type 2C, the inner labia and the clitoris if it is a type 2B. And you can see that sometimes some types can be subtle and the recognition can be difficult. This is why training is so important. Type 3 is infibulation, which is the narrowing of the vaginal orifice with the apposition of the labia, with or without cutting of the clitoris. And there is a wide variation in the appearance of the genitals, as the narrowing can be more or less severe. And then there is type 4 that includes all the other types that are not included in the first three, like piercing, for example, nicking or pricking. And as you can see in the picture here, sometimes the diagnosis can be difficult because you might see the nicking, so a little scar above the clitoral hood, but the person might have also other scars on the genitals, like following obstetric trauma, for example. So you might have a doubt about the classification. Is the labia with a scar because the labium has a scar because of the delivery or because of the cutting? And then there is another modification which is the stretching of the labia, which has been removed by the official classification, but that we still encounter, for example, in our practice. And the beliefs behind this practice are very different from the reductive forms of genital modifications. So again, a few weeks ago, we have proposed an update of the classification under the lead of Dr. Bowers in the US. And this proposal comes mainly from health professionals, because we see that in daily practice, the current classification is, of course, useful. It is extremely important to share a common language and a common documentation, but sometimes there are many types that are between two types or subtypes. And also you cannot really describe the genitals and plan a treatment, for example, only based on the classification. So the proposal, and again, I don't know if this proposal will be published or not, it is currently under review, proposes a new classification system where type 0 contains all the types of cutting that do not involve removal of tissue. Type 1 would be still the removal of the clitoral hood, and depending if we can see or not the clitoris, because sometimes examining you cannot know before an eventual surgery if the glans of the clitoris has been cut or not. But if the glans is visible, it would be a subtype A. If it is not visible, if it is not visible, would be a type B. And type 2 would be cutting of the labia, no matter the inner or the outer. And again, if the clitoris is visible or not, there would be a subtype A or B. And type 3 would still be infibulation, so the narrowing of the vaginal introitus, without distinguishing if it is the inner or outer labia. But again, we would describe according to the fact that the clitoris has been cut or not, with subtypes A and B. So this proposal simplifies a little bit the classification and gives a little bit more details about the anatomy and also the severity of the cutting in terms of anatomical parts. It has been mentioned that worldwide, there are 230 million of women and girls estimated to have or be at risk of female genital mutilation or cutting in many countries of the world, including high-income countries that are destinations for migrants. And it's important to say that data do not have always the same quality. Sometimes we have outdated or small-scale studies or even anecdotal accounts, for example, in case of adopted girls, and data inform policies, health campaigns, and so on. So it's also important to acknowledge that the practice is dynamic and it is not stable. FGM has decreased in several countries, but remains stable in countries like Somalia, Mali, the Gambia. And when we work on this subject, we really need to acknowledge changes in the host country, in the home country, and know that there are differences. And such differences can be very valuable when we share information, practices, and data. Among the most of 600 women and girls residing in Europe, the majority of them reside in the UK, France, Italy, Spain, Germany, the Netherlands, and Sweden. But I would like to underline that these are also the countries that are more invested in producing data, maybe research, producing material on the subject. So we do not have many data, as you can see in the gray part, even if these data were published in 2021, so something might have changed. So it's also important to pay attention to the lack of data and to the lack of information about the presence of girls and women with female genital mutilation or cutting in several EU countries. And only few countries, also when we talk about risk, for example, and we can mention Spain, differentiate between high and low risk scenarios according to several factors. And we will talk more about that later. Different countries receive in Europe different ethnic groups. So different traditions, different types of cuttings, persons that might have different experiences, and also different positions regarding the practice in new generations. So again, when we train about female genital mutilation, there can be differences if you are talking about Spain, or for example, I work in Switzerland. Switzerland has a very different population if we compare the data with Spain. We mainly work with women and girls that come from East Africa. And so the experiences that are shared and the data that are shared might differ. And so needs might differ. Currently, Nasteha Saleh is a PhD candidate in our institution, and actually she's working on improving the prevalence estimates in Switzerland, because nowadays in Switzerland, we only have indirect estimates. And when we assess risk, we only mention the original country of the girl. And such changes are not always easy to be assessed. It's challenging to accurately assess and measure them, and then adjust the estimation of risks. So for example, if we look at Geneva, the city where I run the clinic, and we could consider only the nationality of the children, thinking about the countries that are considered high prevalence countries of FGM, and then we would have 1,376 children that have a nationality of countries considered at risk. But then if we change our perspective and we consider the children that were born and then reside in Geneva with at least one parent from one of the FGMC countries, then the number is almost the double. But these numbers should also take into account several other factors to adapt policies, prevention messages, protection measures, and so on. And we talk a little bit more later. So most of the European countries have ratified international and regional treaties. They have implemented laws and provisions criminalizing female genital mutilation or cutting, and most of them have adopted specific provisions mentioning female genital mutilation or cutting. And in most of the cases, there is no mention of consent or age at which female genital mutilation is performed. Why am I talking about that after discussing terminologies and definitions? Because, so first we saw that the definition of WHO does not mention consent. And this can sometimes raise discussion in the legal field. I will give again the example of Switzerland. So the Swiss government, when there were discussions about the penal Article 124 of the Swiss Penal Code, it was decided because of piercings and labiaplasties that there would not be can you please mute the microphone? So there was no mention about consent. And the choice was to leave the issue of consent to case law. So why is this important? Reason, because the definitions change in different countries of Europe. Sometimes there is no definition about female genital mutilation in the law. Sometimes There is no mention about the type, the severity, the tissue involved. Sometimes the definition is the same as the one from WHO. Sometimes it is defined differently. And I will give you an example of something that we have also written, and this paper is under a second review. So our clinic in Geneva exists since 2010. In the last 3 years, we have started to receive Caucasian patients that feel genitally mutilated after having undergone female genital cosmetic surgeries involving the inner labia and sometimes the clitoris. So 3 of them, 3 of a few more, have consented that we write about their experience and especially that we raise the challenges that these situations might raise. So this feeling of being genitally mutilated led women seek care in an outpatient clinic that usually receives migrants, refugees, second generation or naturalized patients that originate mainly from African countries. And so in this paper, we discuss clinical implications, health insurance coverage, legal, ethical, and social implications. And this is basically to show that there are so many unresolved issues that must be carefully addressed by scientific societies, legislators, and anti-FGMC advocates. Most of the prosecutions for female genital mutilation or cutting happened in France and Spain. And in France, most of them ended in conviction, and Spain to acquittal. In addition to prosecution, we can talk now about prevention and protection. Most of the countries have obligation to report female genital mutilation, sometimes only for certain professionals. But one thing is rules and laws, and one thing is what happens in the field and the training of the people that are supposed to report, to safeguard and protect. And also to respect an eventual obligation to protect or report. And sometimes the obligation to report is not applied only to adults, but also to children. And for example, the reporting of adults, it is not always respected. I'm giving the examples, for example, of Italy. So how do you report and how do you assess risk? It is extremely important. I'm sorry, there is someone with an open mic, if you can mute it. And so when you assess risk, you have to have tools to assess a risk and going beyond a geographical origin of a family, of a child, of a girl. And only a few countries in Europe have developed tools that can be useful for health professionals. One example is Belgium, that created this detectometer. And actually, it is interesting to see that there was an evolution. At the beginning, you had this arbre décisionnel, this flowchart to assess a low risk, an intermediate risk, high risk, with indications on what to do. And now you have this detectometer, and I'm aware that France is adapting this, for example, but for other countries have rules and laws, but no tools. And health professionals or social professionals, psychologists, different professionals in different fields need training and need tools. They need to know how to protect, how to inform, how to counsel, and how to assess risk. Going beyond geographical origin, other countries have developed a compromiso preventivo, so a compromise that parents can sign and engage in protecting the child, agreeing with an exam after an eventual trip abroad in the home country. Several countries have now the so-called passport against female genital mutilation. So this is available in different languages. I have only included a few examples. And again, I'm giving the example of Switzerland, which is a country with different cantons. So different cantons might have different rules about the mandatory or possible reporting and safeguarding. And so, for example, the National Networks Against Female Circumcision created a few years ago a guide with very important information, depending if you work in a German-speaking canton or French-speaking canton. And this is in the field is extremely useful to improve prevention. And this summer, Switzerland too has now a letter of protection for children and a passport translated in several languages. And we have started to use this in our outpatient clinic, and the families appreciate it very much. There are several key moments where prevention and protection can happen. And one of these key moments are travel medicine consultations, because we always think of obstetricians and gynecologists, social workers, psychologists, pediatricians, but travel medicine specialists are also key persons that can provide information, assess risk, prevent, and eventually protect. The UK and other countries, an example is Portugal, for example, that has written about that, have proposed also flowcharts to help health professionals that work in travel medicine consultations. But then when we look at the training of these health professionals, infectious disease specialists and travel medicine specialists, we can see from the work of Tante and colleagues in France that training is lacking. How do you discuss this? How do you avoid stigmatization? How do you provide appropriate information? So tools on one side, but training on the other side. And of course, safeguarding has raised the problem of stigma. Messages need to be adapted. As I said before, it is necessary to go beyond the geographical origin and to have the tools to discuss appropriately, respectfully, and scientifically the subject. And so End FGM, together with other authors, have insisted on the importance of including communities when you develop such tools and when you define also policies and the research agenda. Because we know that even before migration, but then also with migration, there is often an abandonment of the practice, or at least a change in the practice, with different factors involved that are social, communitarian, interpersonal, personal, and so on. But this is not the subject of the presentation. Other challenges regard asylum. So we all know that the likely of being subjected to female genital mutilation or cutting, together with other situations that I'm not listing here, may qualify for refugee status under the Geneva Refugee Convention and Protocol. And in 2017, for example, 66,000 women and girls from FGMC practicing countries sought asylum in the European Union from several countries. So you can see here the main countries of refugee seeking and the main countries where the asylum was sought. I'm showing this because the conditions, the laws can differ too, and this raises challenges again. If we look at examples like France and Belgium, the information about the asylum application and female genital mutilation is pretty available. It is well available on the internet. And at the same time, we can see that there are specific rules that are not present in other European countries. For example, if we look at the website of the Office of the Commissioner General for Refugees and Stateless Persons, we can see that it is stated that the parents have to sign a declaration on honor by means of which they commit themselves to send once a year to the organization a medical certificate stating that the daughter has not undergone any form of female genital mutilation. Same thing in France. There are compulsory drawn up by a forensic medical practitioner working in a hospital unit specializing in the forensic care of the living, or in a unit specializing in the care of female victims of violence, certificates that have to be provided even after the permit of staying and the refugee status has been obtained. And actually in France, in Belgium, we have seen that it was once a year. The legal representatives of a minor child benefiting from refugee status or subsidiary protection are asked in France to provide the certificate every 5 years or less. Such certificate has to confirm the absence of female genital mutilation or cutting. This does not happen in several other European countries. Again, I'm giving the example of the country where I work, in Switzerland. As a clinic, we are consultant for the Secretary of Migration. So we receive some patients that come to obtain the first certificate that testify the presence of FGM or the absence in the daughter of FGM, but this is asked only the first time. And then we don't have to renew such a certificate. And there have been comments and documents published by some scholars questioning these policies as stigmatizing or traumatizing, asking questions about the setting of such examinations, for example. So this is another challenge that could be studied, discussed, and probably improved. Also, how do you provide a certificate? From countries like Belgium and France have some forms that are available, easily available online, even for persons that want to get information, but other countries do not provide information at all on how and where obtain a certificate. And we saw the example of France and Belgium, but it's important to look to other settings. For example, it is interesting to also look at these reports and think about refugee seeking persons that live, for example, in settings where there is no training about female genital mutilation or cutting, where there is a complete lack of information available for asylum seekers. The interview mechanisms might not be geared to support survivors, and also the evidence of physical or psychological consequences might be hard to be documented. And the heaviness of a certificate provided by a physician of the hospital or by MSF, as stated in this report, might be different. And most of all, there is often a lack of awareness of the staff, the medical, legal, and psychological staff, and the persons that have experienced female genital mutilation might not disclose it, maybe they're not examined, they might be ashamed, or they might not think that it is important to disclose the history of female genital mutilation. This report, for example, shows that among the 53 survivors surveyed, most of them, they were women, they were coming from high prevalence countries, they were survivors of human trafficking, and 83% had experienced female genital mutilation. So you can imagine that the setting up for obtaining a certificate is completely different if you're living in the close controlled access center in Samos, or in Geneva, for example, where you're easily referred to a clinic and obtain a certificate that can be used then during the procedures. So we know that female genital mutilation or cutting is usually carried out in infancy or childhood, most often before the age of 15, and signs can be subtle, particularly in prepubertal girls. Most of the training that exists, most of the teaching material has focused on adults, also because there is a lack of studies on minors and children, especially on mental health, for example. So there is a lack in pre- and postgraduate training. So as professionals and also health professionals, we need to ask, but we need to know how to ask. And then we need to know that female genital mutilation does not always leave a visible trace, and that psychophysical and sexual health complications are not always proportionate to the physical scar. So first of all, we have talked about the law, the certificates, asking the question, and now we can talk about examination. So the examination has to be child and person centered. And again, challenges in Europe exist according to the setting and the resources available, in addition to the training that we all have received. Because the examining clinician should have experience in vulval examination, if needed in the examination of the children, and we need to look at areas that we are not always trained at looking. For example, the clitoral area and the periclitoral area, we are not often trained in this area. Even child sexual abuse experts are not always trained about the clitoris. When available, multidisciplinary services, certified interpreters should be available, psychological support, play therapists. Again, this depends on the resources available. And most of all, repeated and possibly traumatic examinations should be avoided. Eventually, with an informed consent, images can be recorded in an appropriate way and with good quality. And if no recording images are available or possible, the documentation has to be precise with drawings, for example. Training is important in examination, in communication, and in trauma and culturally informed approach. In my next slide, there will be some pictures without female genital mutilation or cutting, but with possible differential diagnosis. So situations that can be mistaken for female genital mutilation or cutting. So I will change my slide. I'm showing this because these are all experiences that happened in our clinic, and one picture comes from a colleague from the US, here below on the left side, where healthy genitals without female genital mutilation were mistaken for FGM, with important consequences. For example, reporting to social services, or the call of the forensic on call, or the social assistant at emergencies, and with a big impact on the family that was consulting, sometimes neglecting a possible diagnosis that has to be treated in a completely different ways. So it's important to not to mistake the simply prepubertal underdeveloped inner labia for removed labia, or labial adhesion following inflammatory processes, hypoestrogenic state, lichen sclerosis, or other vulvar conditions that can mimic an infibulation, other traumas, or even malformations of the genitals. It's the case here on the right below, where the absence of a visible clitoris made think that there was a cutting of the clitoris, but actually it was an epispadias, which means a defect of the fusion of the clitoris. You can see the two hemiclitorises on each side. And actually this child needs to see the pediatric urologist instead of the FGM specialist. So in case of doubts, ask for second opinions and do not rush with a diagnosis of female genital mutilation. This has to be underlined, not just for medical reasons, but for trust reasons also with the family, and also legal reasons. You have seen on the newspapers in different times that the consequences of wrong diagnosis of female genital mutilation on physicians, on families, and so on. So training again. I always show this study that we did just 2 years after we started our clinic. It was 2012, to show how in a university hospital where there was a specialized clinic existing already since 2 years before, protocols and some training already happening, how the lack of correct diagnosis, recording and coding was happening. So out of 129 patients that came to our clinic, before we looked back in their medical files, and in more than 1/3 of the medical files, it was written that there was no signs of lesions on the genitals, and 60% of these patients had female genital cutting type 3. So after seeing that, we were worried and we thought, what can we do? How is this happening? So we repeated a similar study in 4 university Swiss hospitals, Bern, Geneva, Lausanne, and Zurich, and we looked at inpatients and we tried to look at coding of inpatients. Out of more than 5,000 persons, women and girls that had been inpatients in these hospitals in different departments that might have had a female genital mutilation based on the indirect prevalence that we applied, only 207 persons had a code of female genital mutilation or cutting. And this was, so that coding was also in OBGYN divisions. It was a little bit better in Geneva because there is a specialized clinic, lots of training, but still we were also bad, the Geneva University hospitals. And so we tried to look specifically in different professions, and we decided to contact the HIV Swiss cohort, which is a very Swiss old cohort that follows up patients with that are HIV positive, that works very well. They have questionnaires, they're well trained. And so we proposed only for 6 months to include 2 questions. Have you experienced female circumcision or genital cutting during your childhood? And the second question, if the answer was yes, Have you ever had the chance to discuss about it with a healthcare professional that might be a doctor, a nurse, a midwife, and so on? And the questions were only asked to those persons that had geographical origin considered to be a high prevalence country of female genital mutilation or cutting. Before starting this study, we trained the HIV specialists, we provided material, referral measures, and so on. In spite of this training, in more than 1/3 of the eligible patients, the question was not administered, and when it was administered, 21% of the almost 400 patients declared that had undergone female genital mutilation or cutting, and 70%, so 70%, had never discussed about it with a health professional before. This was a few years ago. Why is this important? We are in an HIV cohort, so these patients are HIV positive, they might be immunodepressed, they might be at increased risk of genitourinary infections, cervical dysplasia, not only for the HIV, but also for the female genital mutilation. They might encounter more barriers for care. So the fact that the health professional does not ask the question and does not discuss possible complications, does not offer counseling, and so does not discuss eventual prevention is important and needs to be addressed through training and sensitizations. Training differs a lot. So this is another challenge in Europe. So pre-grade and post-grade professional training changes. It can differ, the resources can be different, and even within the same country, there can be very big differences between different centers and different geographical regions. Some countries like, again, Belgium, Spain, have produced very important resources that could be shared, translated, adapted without reinventing something new, because there is very good material that has already been developed by several colleagues in different countries. And something also that needs to be mentioned is that female genital mutilation or cutting is part of the ICD coding, so the International Classification of Disease. And this has huge implications in terms of refunding. For example, I'm talking about Switzerland. Until 2015, we always had to write a letter to the health insurances to make an approval before doing surgery, for example. Since the entrance of FGM in ICD coding in Switzerland, we don't have to do it anymore, and refunding is automatic. But ICD code can also help to obtain direct estimates instead of only indirect estimates. The problem is that coding doesn't work. We have bad coding. We looked at this during a study in the 5 university hospitals of Switzerland, because we wanted to assess, for example, the quality of care in the delivery room, the rate of C-section, the blood loss, the rate of episiotomy. We wanted to count the procedures of defibrillation, but this was not possible due to bad coding. If there was a better diagnosis, a better documentation, and a better coding, we would have a lot of information that are direct and do not need to pass through surveys or specific studies. So one intervention, of course, is training, but to improve diagnosis, recognition, discussion, and then recording, we can also do a lot of other things. For example, we can improve the informatic medical files where they're used. For example, this is our experience. We introduced back in 2012, after the study that I showed, that showed very bad documentation and bad diagnosis. We introduced a specific checkbox that mentions female genital mutilation. So the health professional can think about it. And when he or she doesn't know the classification, then there is a little click that she or he can do, and the classification appears together with a learning tool that we created in 2016 with drawings, pictures, and so you can recognize and classify in the medical file and maybe discuss more with the patients. So now the obstetric and gynecological medical files have been updated with this. And other examples of practical trainings should happen in the midwifery school, nursery school, with residents that have to be trained in communication, diagnosis, but also treatment. So this is an example of very cheap simulation of defibrillation at the midwifery school of Vaud, for example. This is a little bit more expensive model to train defibrillation with our residents, for example. And these are our med students in the practicals of anatomy. We have introduced a course that shows the diversity of the external genitals with penis or with vulvas. And among this diversity, we also explain the diversity in the anatomy in case of different types of female genital mutilation or cutting. And in my opinion, it is very important that female genital mutilation is not treated as a completely separate subject, but that this is also included in the already existing subjects like anatomy, urology, pediatrics, gynecology, travel medicine we were discussing before, so that future health professionals, even at the pre-grade stage, can think about it, about possible conditions that they can take care of. My next slide contains one picture, because now I'm talking about treatments and disparities and challenges in treatments in different European countries. So other challenges regard access to a holistic, scientific, evidence-based, culturally informed, trauma-informed, so many things, care after female genital mutilation or cutting. So the maps that I present here are not completely updated. For example, Switzerland now is green, so things might be different, but the access to a holistic care is very different in different countries of Europe and also within the same country in different regions. Sometimes patients have to travel a lot to have access to their care. An example is defibrillation, for example. We know that defibrillation is the promotion of the health of a person that has an infibulation. It improves a lot of his symptoms. It allows diagnostic procedures, it improves obstetric outcome, and so on. But the type of care in case of defibrillation can be different. For example, the access to have defibrillation under local anesthesia, local regional anesthesia, general anesthesia, the possible mental health care associated with defibrillation that can also raise these important cultural, psychological, physical changes. It is not always the same for patients living in different countries in Europe. And also, it is important when we talk about defibrillation, not to stop to the moment of the surgery, but also to talk about after the surgery, because the change of defibrillation is quite important and the patient cannot be abandoned at the moment of the surgery. And post-op care, care of eventual pain, accompanying the patient of in the change of the way of the micturition of the genitals and so on, needs to be there. My next slide has another picture, because I'm talking now about reconstructive surgery and again, access to reconstructive surgery. Challenges are also there. So there are huge differences in the access in general to reconstructive surgery after female genital mutilation, and particularly reconstructive surgery of the clitoris. 2 years ago, End FGM Europe organized a meeting where one surgeon from each country was invited to share practices, techniques, clinical experiences, and to inform also future possible clinics in other European countries. It was a very fruitful meeting, and in February of this year, also with the endorsement of End FGM, the Geneva University Hospitals organized the first masterclass in surgery after female genital mutilation or cutting. And this masterclass wants now to produce some teaching material and consensus material. Why? Because when we talk about clitoral reconstruction, now there are several peer-reviewed and recognized techniques of clitoris or labial reconstruction, but they have been studied just a little bit with the studies that are not always of good scientific quality. There is no much literature on the management of adverse outcomes. We have now different indications, sometimes for pain, but the image sexual response. And most of all, there is not equal access to multidisciplinary care, mental care, and non-surgical care. And also, of course, there are differences in refunding. This is not the subject of this presentation, but it's important to say that one challenge is to standardize the technique and standardize also the non-surgical care that is associated to this eventual surgery. And also to make available information for patients that are thinking about this eventual surgery. In the UK, there is currently a campaign to make the national system to offer free reconstruction together with mental care and psychosexual care, because for now this is not available. And then I was mentioning about the information. I'm arriving at the end of the presentation, that I would say this is a very, very important subject, because yes, we need to train the professionals that work with survivors, patients with female genital mutilation, but the persons need to be informed and to make informed decisions about themselves, about their reproductive health, their sexual health, about when they talk with their daughters and their children. And so now there are some few information. The slide is already packed, so I'm sorry if in the audience there are other people that have produced. There are so many now tools. But what I want to say here is that there are now brochures, leaflets, videos, some web apps, and they should be studied. The persons that are concerned should be involved in the development of the information material, and such information material should be evaluated, used, and shared, so that, because it's a lot of work to produce, I'm thinking, for example, of the video that GAMS developed together with other colleagues about defibrillation and clitoral reconstruction. We always use them in our clinics. They're very appreciated by the patients. And so it is very important that a tool that is developed is then shared and can be used and eventually adapted in different countries. So in conclusion, we know that there are more than 600,000 women and girls that are estimated with or at risk of female genital mutilation or cutting in Europe. There are differences and challenges in Europe, with different ethnic groups, different generations living in different countries or areas. Training changes a lot. The access of eventually refunded holistic care for persons with female genital mutilation or cutting also differs. The available information is different. Assigning procedures, we saw also that can differ. Laws, resources allocated to the subject of female genital mutilation or cutting. So we need to have adequate tools, adequate risk assessment, adequate care without stigmatization, and to reach a competent care, we need training. One step is to include female genital mutilation or cutting in different subjects, as I said before, but it's something like the End FGM E-Campus would be very valuable to improve training, and so to improve also collaboration within Europe, sharing information and good practices, materials, communication, data and research, very important. Until now, we only have a very few single center studies and not multi-center studies when it comes to research on health outcomes of different surgeries, for example. And last, it is very important to involve the persons that are concerned, being inclusive of diversity, because as a health professional, when I do my clinic, I listen to so many different voices, but these voices then do not always reach the media or the general discourse about female genital mutilation or female genital cutting. And the voices need to represent also the diversity. So thank you for the invitation, and I wish a lot of success and a lot of useful application of this very important free online learning platform. Thank you.
Thank you very much, Dr. Jasmine, for such an insightful presentation. I am sure that the audience is now looking forward to exchange with you some questions or comments. I'd like to open now the floor to any questions or comments. Please, you can write into the chat box, into the Q&A chat box, or into the chat, or raise your hand and we will give you the floor to speak. We actually have already one question from Fabienne, addressed at Dr. Abdulcadir. I will read it. She says, is it difficult It is difficult to estimate the number of girls born in Europe who have undergone FGM during travels in the country of origin. We know that doctors and medical professionals are afraid to disclose those cases, thinking of the risk that the child will be removed from the family. Do you think that anonymous and confidential registration of those cases, as UK did with maternal mortality, maternal death inquiries, could be a solution to have a better view of the incidence of FGM on girls born in Europe during a travel?
Good morning, Fabienne. It's a very important question and a difficult question to answer, because even from an ethical point of view, like I'm thinking even just about the approval of the ethical commission of such a study or such a project, it would certainly raise some questions. So I'm curious to hear also the opinion of Fabienne, but now in Geneva with Nastea Sala PhD project, she has conducted a study also assessing attitude on cutting, and the question that we have included is, hypothetically, if you had a daughter, what would you do to avoid the disclosure of an eventual vacation cutting or cutting? So I think an anonymous registry or observatory could be useful, but the problem is that we are talking about minors, and an eventual project about that should include a very big reflection from a legal point of view, ethical point of view, and risk point of view. If you know about one child, what about the eventual daughters, sisters? Do you have to do something? So I don't have an answer because it's a very difficult question. And do I read the question? And I can see there is
Yes, you answered the question.
Yeah,
Maybe
so
if Fabienne want to react, we can give her the floor. Maybe Fabienne, if you have any reflection about that, you can share with us, please.
And in the meantime, I can read the other question. We received in Belgium multidisciplinary FGM center for women who had reconstructive surgery alone without psychosexual support, and they come to us to say that nothing changed. So this is to emphasize the importance. Yes, and yes. Actually, it is very difficult to separate the outcome of psychosexual care and surgical care. So there are countries like Belgium, France, Switzerland that really insist on the non-surgical part of the care. We also received in our clinic patients that only had surgery, that do not see a difference, or actually that ask for a second surgery to improve their health. And I think that future research should not only focus on surgery, but actually we should focus on non-surgical treatments that might be equally effective, especially for some issues, and could really improve the health, psychosexual health, psychotrauma, and so on.
Okay, we have some people that raise their hands. For order of appearance, I will give the floor and allow to talk to Juliet de Klerk. Could you ask your question? You should be able to speak now. If not, we will give the floor to Fadwa. Please, Fadwa, could you ask your question?
Hello, can you hear me now?
Yes, we can hear you.
Yes, my question, thank you for Dr. Jasmine, very useful information. My question is, can I share the video? Can we have the video and share it with my colleagues?
Yeah, we will have the video, we will post it online, and you will be able to have access to it.
Thank you so much, very useful information. I would like to be invited to like this webinar always. Thank you so much.
Thank you very much, Fadwa. Now I'd like to give the floor also to ask her question to Gloria Boadi, that has raised her hand. Hello, Gloria. Could you ask your question to Dr. Jasmine? Okay, then I will give the floor to Elizabeth Ideugo. I will enable you to talk. Could you ask your question to Dr. Jasmine, please? Elizabeth? Okay, so seems that the people that raise their hand, we will go to the chat box again.
There are
And
many
see-
important questions, and
We have,
sometimes
yeah,
very important.
we
So,
have a lot of questions.
yeah. So do I go in order of the questions? There is a question about different forms of genital mutilation, and that there is a start of collaboration of women who are unhappy about their labiaplasties. And Matthias is wondering if a similar collaboration would be possible with people suffering intersex procedures without their consent. Yeah, I think so. I think so. And I think while there are differences when we talk about these different genital modifications, I think it is very useful that we keep a communication between different scholars working in these different fields when we talk about definitions, laws, so that we can be inclusive and have very important insights. And I'm a clinician, and in my clinic, I start also to receive, it is called FGM clinic, and I start to increasingly receive patients without what is called female genital mutilation, but with failed labiaplasties, intersex surgeries, or other surgeries, especially when they were children and could not give consent. So I think it's an important subject to raise. So thank you for your question.
We have another question from, excuse me, we have another question from Sarah. She says, thank you for your presentation, very insightful. I am a young researcher in human rights law, and I was wondering whether in your professional life you have perceived by talking with women and girls who have undergone FGM that sometimes legal tools are not enough or maybe even become an obstacle.
Yes, yes. And I think one side is information. Well, we could enlarge the topic in general, talking about violence against women and laws when it comes to violence and rights. So it is not a new topic, but yes, I agree with you, Sarah, that there can be a lack of information, a lack of access. I mentioned this only when I mentioned about asylum seeking, for example. And I don't know if you're referring also about, as an adult, if you want to press charges for what happened when you were a child. And this also is a field that has been just a little bit explored and studied. So as a young researcher, I hope that you can maybe work on this, because it will be useful. And it opens a lot of questions about parents, family relationship, not just legal questions, but very, very deep questions that have not been addressed.
Thank you very much, everyone, for your questions. We should wrap up now this part, unfortunately, since we don't have much more time. And now I would like to give the floor over to the Mediterranean Institute of Gender Studies again to walk us through some key features of the End FGM E-Campus platform. Dr. Kylie, it's over to you.
Thank you very much, and thank you, Dr. Abdulcadir, for your exceptional presentation, which also gives a lot of insights into the current challenges in training and policies, which of course all of them are addressed in the different e-learning modules of the portal. Thank you very much. I'm sharing my browser now. Great. So you can use any of the usual browsers you're using on your computer and type endfgm-ecampus.eu. In the upper right section of the website, first-time users can sign up. It's a very short form to complete, and of course accept the terms and conditions of the website. It's an easy process. and at no cost. There's no cost for registering and signing up to the e-learning platform. And here, after you create your login credentials, you can enter the portal to choose. I will navigate quickly, as I'm aware of the time. I will navigate quickly the homepage of the portal. The key features of the platform is the e-learning course comprising 5 e-learning modules, which I will go through shortly, and country-specific information pages. This section is coming shortly in October, available in French, English, Greek, Italian, and Portuguese, together in synergy with the End FGM interactive map, which also has another more than 16 countries, country information pages, providing information about policy frameworks in these countries, available data, and also available support services. Also, some other related links to our partnership and endorsers, the social media of the portal, and contact details. Here we have a resources section where you can find a useful terminology and definitions glossary, which will soon be also available in other languages, and associated leaflets for those who are interested to find out more or disseminate the portal. Of course, about the project and the course which we are launching today in English. It's comprised by 5 e-learning modules, as I said. The introductory module on female genital mutilation, which I will go through quickly with you today to get an idea of how a module looks like. It's a foundational module. We recommend that you complete the introductory module and then move on to one or more of the specialized modules on the health consequences and management of health consequences of FGM, protecting the protection module, which is about the protection officers in the field of asylum, in the field of child protection, in the field of law enforcement. The prevention module tackles preventative measures around FGM, and the module around community engagement, how we engage communities, as addressed in the previous presentation, how we talk, how we communicate with the community. Let's go through the first module. So as soon as we enroll, there is a dashboard where you can also see which modules you are endorsed in. You can see it here, in my case, where I enrolled all of them. You can see the level of completion in which module. As I said, the foundational module is the first module. So it's always useful to, sorry. Go here. Yeah. Each module has an introductory video featuring the key learning objectives of each module, what we will cover in the module, and it's divided in different units as per the thematics of the module. Each unit, after you complete it, you can go through a self-assessment, a short self-assessment, which is not, it's to support you to finish the final quiz. For example, if we go through the introductory section, the unit 1, there are definitions with associated links, references, terminology used. The introductory module also covers a lot around what the previous presentation also stressed out. This tool is also to comply. It complies with the EU policies, legislation, the newly adopted EU directive and the Istanbul Convention that addresses the issues of FGM and the importance of training professionals. So this is the commitment under which the member states should provide this training to professionals. These are some when and how FGM is performed, the consequences of FGM, again with hyperlinks and references to additional resources. A short quiz to move on to the next unit. So let's say you make a wrong question, you give a wrong answer. You also have the opportunity to retry and a short explanation. We have also different types of activities to match. It doesn't matter if you give, you can retry until you give a correct answer in the different questions, but it will not stop you from moving on to the next section. Let's go back to module overview. And after we complete the different units, and we have a key takeaways section. For each module. And in order to download your module certificate, you need to pass 8 questions out of 10 in the final quiz. Of course, you are given multiple chance to retry. Before you download the module certificate, we ask you to complete a short feedback form for us to improve also the learning experience and also to also provide your feedback about the module, about the platform experience, which we very much appreciate. And then you can click and download your certificate. Will be downloaded in the in your downloads. I don't know if you can see it now that it was downloaded. Let me turn it off. I will also share the presentation.
Okay, thank you.
It's time's up.
Yeah.
We also have, you can contact us as well in the email for any questions you may have about the course, and we very much invite you. Your details will be used to send you emails for the additional languages available when they are available, the modules in the other languages. And thank you very much for your attention. Carol, I can't hear you, sorry.
Sorry, I was muted. Thank you very much, Cristina, for your presentation. Now it's over to Eidos for the closing remarks. Clara Caldera is the President and Program Officer of the Italian Association for Women in Development. Dear Clara, the floor is yours for the closing remarks.
Hello, good morning. Thank you, Gerald. I'll start by thanking Dr. Jasmine Abdulcadir, who, apart from being an amazing medical doctor and a huge expert on female genital mutilation, is also a passionate woman capable of conveying her knowledge and practice in a simple and effective way to a wider audience, even to people who are not medical doctors. Grazie, Jasmine. As Jasmine pointed out, several needs for professionals dealing with persons, women and girls at risk or survivors of female genital mutilation. I'll try to summarize the main points, the main needs. Firstly, professionals need to consider differences and challenges in Europe, such as different ethnic groups and generations living in different countries or area, but also differences in access to holistic care for persons with FGM, difference in available information, asylum procedures, laws, difference and huge differences in resources allocated to female genital mutilation. In some countries, we have dedicated budget to that. In others, there are no specific budgets, for instance. Furthermore, professionals need to be able to carry on adequate risk assessments and deliver care without stigmatization. That is why they need practical, adequate tools, such as the flow chart on risk assessment or the passport that we saw, together with trainings and also practical trainings on FGM. And in particular, trainings to be included in already existing university courses in order for professionals to be able to deliver competent and cultural appropriate care, care that is centered on the well-being and the rights of the person, of the women and girls that are concerned by female genital mutilation. So trainings in pediatrics, urology, travel medicine, of course, but also in legal, psychology, social, and other kind of courses. Another important thing we need is sharing and collaboration within Europe. Good practices and materials, communication, data, and research. As said, there are many available materials and practical tools and research that may be further shared among countries and among professionals. Moreover, we need the involvement of all the concerned persons in all their diversity. So we need really to be more inclusive. Last but not least, and above all, it is crucial to challenge gender norms and stereotypes that are the root causes of any form of gender-based violence, including, of course, female genital mutilation. So the E-Campus platform aims to address some of these needs, as it is intended to support professionals in their journey to further and better prevent female genital mutilation and provide holistic care to women and girls at risk or survivors of FGM. So it is meant to be the tool that we needed to both complement and stimulate trainings and exchanges among professionals in Europe, and we hope beyond Europe. So you may find more information on the platform, and also you may contact info at End FGM E-Campus EU for further support and further resources. I hope I stick to the time.
Yeah, you did. Thank you so much, Clara. Now I would like to give you the floor to Nejma Sayeh, that is the Policy and Advocacy Officer here at the End FGM EU Network, for the final words. Thank you, Nejma. The floor is over to you.
Hello, good morning, everyone. On the behalf of the End FGM European Network and its partners, we would like to thank you all for taking part in this launch. And obviously a special thanks to Dr. Jasmine Abdulcadir for your insights. I think it really illustrated the emergency of the situation and the need in Europe to take concrete actions to end FGM and support those affected. For me, one key takeaway from this launch is that as professionals in touch with FGM survivors and affected communities, you have the opportunity to become change makers and transform lives. And for that, having the right tools is critical. That's what we wanted to create this platform. So now register to the E-Campus, complete the module, learn about how you can be part of the solution, and join us in creating a sustainable change for all those affected by FGM. And one last thing for you is to spread the word. Share the platform widely, use it, explore the E-Campus, and make sure that the world knows. And finally, I also take the opportunity to invite you to join us for our second launch event on the 3rd of October, during which we will engage with decision makers and other stakeholders and to showcase how the E-Campus platform can be a powerful tool for change. Thank you so much.
Thank you very much, Nejma. The time has come to thank you all once again for your active participation and for joining us. I wish you all a lovely day and see you all very soon using the E-Campus, the End FGM E-Campus platform. I wish you all a nice day.
Thank you very much.
Thank you, everyone, for joining.